And welcome back, guys, for part two of our hip mobility series. And I am Dr. Brett Scott, and with me here again is Dr. Connor Bombassi.
Happy to be
So,
here.
thanks for being here. So, we just kind of gave an overview of why hip mobility is important and why just general joint mobility is important, with kind of context to more of the hip and why it's important and why training it can be crucial to not only performance but long term health and wellness. Part two, I want to go a little bit more down the rabbit holes of what we see clinically, scientifically, and just kind of nerd out and rant out a little bit. So, um, first off, is as I said in the first part, I used to think that stretching was garbage, working on mobility wasn't worth it. There were other things you could do, just train right. Pain is all in your head.
Can I just deadlift and it will feel better?
Yeah, telling yourself it's not going to hurt. And some of this is true. A lot of this can be true. But again, it always depends. The reason I wasn't a fan of stretching is I was very much in the middle of diving down the rabbit hole of pain science. And then I even took Greg Lehman's course, which is a great course called Reconciling Pain Science and Biomechanics. And I got a lot out of that course, and I've been able to help plenty of patients and clients thanks to that course. And there's a whole lot of power in pain science and understanding it. And uh, on the sport performance side, and me and Greg actually had some great conversations within the course class discussions about this. There is a huge piece of biomechanics that has to do with performance and relatively why biomechanics are so important is for sport performance, right? But we've looked at the data and we're going in some different routes. So now we're starting to say, and I think trainers and higher level athletes are starting to get a grasp on the fact that my spine doesn't need to be completely straight when I deadlift. It can flex a little bit, or it can flex a lot too, depending on the person. Uh, However, caveat to that is we still don't have any data saying it's good to deadlift with a rounded back. That's still not out there yet, to my knowledge. And back when I took that course in 2018, it wasn't in Greg's knowledge either. So that's one thing we need to think about. But so much of the data, and I think just the common trends in this field of the movement professions have been, yep, just calm things down, right? If it's too heavy, lighten the load, let it heal a little bit, and then slowly, progressively build it back up. Which sometimes that's the case. Some people are under recovering by not sleeping well, eating well, uh, de stressing and coping with stress, and just training too hard. Or sometimes they're training too hard to deal with that stress, and that is their coping mechanism. Now, those are all factors as movement professionals we need to manage, right? Sometimes it is too much load. Sometimes we need to bring it down, especially in the beginning. We need to calm things down and then later on build them up. My view though of the field is like we're not looking at all these little nuances of joint health, joint range of motion as well as we could, because at the end of the day they still do matter, right? And so we can bring up a couple case studies to go over these things and why they matter. So, first one that we discussed, sciatica case, and we see this a fair amount of times. And one of the questions is, what came first, the chicken or the egg? Because a lot of times with sciatica, we will see limited hip internal rotation, limited hip flexion, because this person is now just flexion sensitive. And hip flexion and lumbar flexion. So if I roll myself into a ball or I curl down to grab something off the floor, those are coupled motions. So my hip bends forward and my back rounds out, right? That's flexion. And in a healthy individual that's asymptomatic, that's perfectly fine. Our spine can do that, right? Because it for most of us, it has the mobility to do that. And most of the time, the hip does too. What we see, though, in a lot of cases, I see it especially with powerlifting because we're not training like weightlifting and we don't have these joint adaptations that weightlifters have in powerlifting, is we see a lot more hip impingement uh, from the from the stiffness side of things. So what I mean by that is powerlifters are training to create complete stiffness, to create joint centration and make a joint very stable so that it doesn't move, because when we're under maximum loads, we're trying to keep everything still to move as precise as possible. And when we only move to 90 degrees, that starts to form problems. Now, if there's some other underlying issue here too, say, you know, maybe, and there's so many different aspects to this, right? There's so many reasons why this could happen, but maybe I was sitting in a crappy chair for a prolonged period of time, right? So maybe my baseline hip mobility is, we'll give it a B, right? I can flex my knee and it's pain free, but maybe I don't have 130 or 140 degrees of passive range of motion. So just our joint isn't that mobile. It's kind of stiff where me as a clinician cannot move a hip all that well. Maybe I get it to 120 degrees. And now, say I've taken a long flight, I've sat in a low chair for a long time, I'm sitting in a lot of hip flexion, say 8 hours. My joint is now sitting towards its end range of motion. Okay. And we're basically brushing up against the guardrail, essentially, right? And then I go to lift. And then that day, things feel pinchy, right? I go to squat and I just feel this pinchiness in the front of my hip. Well, what do? I keep training. And then I start to compensate a little bit and the pain goes away. But I've compensated from a point of, I'm not going to move, or my body's not going to let me move where I can't move because it perceives pain, right? It's already been overloaded for the day. And then this goes on for months and months. And we stop feeling the pain, but that joint mobility limitation is still there, right? And then I go to do something like repetitively do yard work or housework or help a friend move or whatever the case may be. Or even I go to hit a max squat and maybe I go lower than I've gone, right? Maybe it's a heavier load and I just sunk into the hole a little bit lower than I've trained, and boom, now I have back pain, right? If we had just trained joint mobility a little more and we didn't have to flex from the spine, maybe this wouldn't have happened, right? So we see this all the time, of if we don't get true joint health and joint care going at one point, it starts to work its way up the line, especially when we're pushing our body to its limit, right? So maybe we don't need more than 90 degrees of hip flexion for the specificity of training, but maybe we need it for the variability of our training. Maybe we're tired. Maybe it's outside tasks. Maybe it's all these other things of environmental factors throughout our day that require us to have a healthier hip, because if I can't flex from my hip, I'm going to do it somewhere else, right? So that's one type of issue we see with this, is this kind of lack of hip flexion in strength athletes that can turn into other problems up the line. Because if I can't flex from the hip, I'm just going to go one step up the chain and start going from my lumbar spine, my thoracic spine, or somewhere else, right? Sometimes this can be an ankle issue too. If my ankle isn't moving at a fundamental level the way I need it to, then yeah, my hip might start hurting, right? So we have this, and we see this stiffness in a lot of people, much like powerlifters. But on the same side, we can still see the same type of symptom in someone that's very mobile too. So if I have weightlifters, gymnasts, runners, anything like that, they can feel the same type of pitchiness in their hip, but it's because they don't have joint control. And so what impingement is just the symptom of a joint closing down, right? So if I come up to the top, it is coming to the point of closing. Now, we can kind of nerd out here a little bit with sensory motor coordination and conduction. Okay.
Booyah! Here comes Dr. Mo.
Yeah, right. So with with joint control and what we know, and this actually comes back to a pain science realm of if a joint is stiff, there's plenty of studies that show we don't have great sensory motor conduction or communication between our brain and our joint, right? And if our brain perceives threat or perceives lack of communication between something, it's going to slow us down, it's going to stop it, and it's going to give us the perception of a pinch when it closes up upon end range or when it doesn't have control of that joint. Okay? So, case in point for the importance of hip mobility and just general mobility is that whether it's a high load to 90 degrees of motion or it's an everyday activity, we need it. And if we are training mobility, we're actually training that sensory motor conduction system to uh, decrease the sense of stiffness, improve tissue extensibility, and improve uh, when we improve that awareness of where the hip is in space and time by practicing actual joint control, we can decrease those symptoms of stiffness, right? And we can actually, through mobility training and long duration time under tension and elongated positions, we can improve what we're feeling there. So, Connor, is there anything at this point you want to add to that?
Definitely. So one thing I want to think about too when I'm warming up for either Olympic lifting athletes or powerlifting, sometimes I feel like I get the question, why do I have so much hip? I call it sometimes activation, but I feel like a lot of times one or two easy sets of something hip activation related, whether it be a hip lift, like a mini band walk, something along those lines. It's just making not only the muscles turn on a little bit easier, but it's also the perception, like you talked about in our brain, kind of connecting a little bit early before we start hitting warm up sets with a bar, just to kind of light things up a little bit easier for us when we start doing those warm up sets.
Yeah, and what those things are really doing is just they're like if I put a mini band around my knee, right? And I start squatting with that, right? I am increasing awareness of my hip because I have this little band telling me, hey, push out into this.
Yeah, the
And
little
so now
external
I'm
cue matters.
that little external cue can do a lot just to say, okay, here is my hip and here's where I am and here's where I'm trying to go, right? And so that's just uh, sensory awareness, right? It's enriching the environment with the cue to create more joint awareness, right? And sometimes that alone can stop a pinchy hip, and people will talk about, oh, we're activating the glutes and this and that, and um, I think some of that's kind of old, um, old trainer jargon and stuff, but it is when we look at the true science of a joint, we can look at it and say it's an external cue that's creating more sensory need for awareness, and it's improving the control of a joint, and it's giving the body the ability to slow down and give it more joint centration in some form to control that range of motion, right?
For sure. And I
So
think regardless of jargon too, we just need to know like it's good for the client or the patient. Like there's a reason behind it.
yeah, and it can be right, and I think that's the thing with training these things like joint control, whether it be active range of motion or passive range of motion, whether it's stiffness or someone that needs to be in better control of their joints because they have these symptoms, right? And they have these symptoms for totally different reasons. The fact of the matter is, we need to train mobility there. And by training mobility, and even if we have a stiff hip and we start to do things like cars or the controlled articular rotations, right? We're improving that sensory motor conduction. And if we can, by doing that, decrease the perception of threat right? We might actually get a little more neurological joint mobility because the body's saying, okay, we have control of this range, or we're now articulating all the surfaces, right?
Hmm.
And I'll stop getting that pinching. Now I can move from my hip again. And maybe when I hit that squat a little lower than I was before,
Without the
maybe
warning
this
lights
time,
going off.
yeah, maybe this time I won't have to flex from my back every time I do it, which could potentially end up with some low back pain or some glute pain or some hip pinching and other things in that situation, right? And that's the other thing too that we know is um, that people don't seem to be catching on to in the field. It's like, yeah, just load it and see what happens. But
Let's see what
we still,
happens.
we, yeah, but we still know that loading a joint to end range of motion still isn't good for a joint, right? That's when we see things like impingement happen. And impingement is just a syndrome, right? But end range loading of any joint, having this closing angle joint pain, can cause issues down the line, like a labral tear. Um, it can cause osteophytes to grow within the within the on the femur, on the acetabular. So we see, pincer and cam lesions and things like that orthopedically, which sometimes they don't matter. In roughly 50% of the time, we see that these things that people can have these things and they
Doesn't
have no
matter.
symptoms,
Yeah.
they have no dysfunction, they go about
Can
their day
squat,
just fine, they can squat, right? They found
deadlift, you name
a
it.
yeah, and sometimes it is just a workaround, right? But if we can, and even if we have these things, right? Sometimes it is just like I have uh, cam impingement, right? So my femur is basically shaped like an oval because I was on skates at 3 years old, so probably from all the all the stress on a groin as a hockey player, right? In a developing body from 3 till 18 years old, I my bones developed a little bit differently because of where we loaded them, right? But that doesn't and so I actually have labral tears on my hips, but I haven't needed a surgery because I've done the work to create more joint awareness. I've actually done a lot to improve the extensibility of the hip capsule and the surrounding musculature, so that when I flex, I'm not going up. And yeah, there's probably scar tissue buildup, and scar tissue is fine too, right? But these are things we should still work on because if we let them go too long, um, and we do keep riding and pushing through pain, well, then you can't move where you can't move, and we're just making things worse in the long run, in that sense, right? So if I can't flex my hip to 90 degrees actively, which I've seen powerlifters that it's tough to get some of their hips to 90 degrees. And then they have these symptoms of hip impingement, which is okay. We can do things to improve it, but maybe we shouldn't squat for a while we're improving that. And maybe we can work it around. Like you can still squat. Okay. I just need you to squat to a box and stay above 90 degrees for a bit until we get this mobility back, right? Because what happens is if you keep forcing in range flexion over this, then we start to see some of those arthritic changes come in over time. And then later in life, if you continue to powerlift, they might become problematic, and you would go to a lot of orthopedics, and they will tell you that. However, if you change the demands of your life, and there's no need for you to squat, past 90 degrees or do some of these things, they might not matter, and you'll be able to live a perfectly happy and healthy life. It's just comes down to what are you doing and why are you doing it? How long are you going to be doing it for? And is this something we want to have to deal with down the line, or can we just do some controlled articular rotations and take 5 to 10 minutes a day to improve our hip mobility, because it's going to help us feel better too. And if I'm squatting all the time and I keep having this pinchiness, I'm going to have decreased force production too because I'm in pain. Our body's going to limit force when it's in pain. So mobility training can actually give us a huge effect on performance by being pain free because we can just produce more force. Period. There's no way around that, right? So why are we just telling everyone, yeah, just keep squatting, don't warm up? Warming up is useless. Mobility training is useless when there's a clear case for actually doing mobility.
I think that's been one of my biggest kind of adjustments for me kind of coming into the private space is kind of knowing that everybody has their own warm up and stuff like that. So starting to give people specific warm ups based on what their anatomy is showing us has been kind of a mental shift for me because I know, like you say, some people are kind of married to their warm up. They've been doing the same thing for 5 years, but your
Mm-hmm.
demands change over time. So I think it's kind of up
Mm-hmm.
to us to, especially as the practitioner, as the coach, give them what they need, not necessarily always what they want.
Yeah. And there's something to be said too for um, adapting to things and training around things while you rehab them too, right? So pain science, biomechanics, they both matter in my opinion. And um, it can be a matter of load management. Okay. If I have someone that's got this on and off hip pinchiness or impingement type syndrome, if you will, or closing angle joint pain, whatever you want to call it, uh, does it only happen when they squat over a certain percent or a certain volume or when they do 10 sets of 10, right? That's probably too much, right? Can we slowly dose it back in? Can we now start to build that hip up, right? While still improving range of motion. Um, and then finding what works for them too. Cause like for me, the the boniness of my hip says, hey, you can't you can't squat with your feet out wide. And I can't squat with my feet straight. I have a narrow stance. It looks weird. My toes are out when I snatch or clean and jerk. I think my heels actually move in and my toes turn out, so my base is a little bit wider, but not by much. But for me, in what I have, right, I have limited mobility, and I did have hip pinchiness for a long time. But what I did over time was I started really hammering 3 to 4 minutes a day of these pails and rails in one position, in that 90-90 position, and um, it takes 4 to 6 weeks to actually start to see some change. But all of a sudden, it's like, hey, you know, I'm getting into my squat and I'm not getting that pinchiness in my hip because the capsule can actually extend now, and my hip has more free range to flex, where it didn't have that before. And so, even though I have cam lesions, I have these bony overgrowths, I probably have these labral tears, I'm still able to improve upon that with mobility training. And my training's been feeling much better lately because I've been doing that. And um, I think a lot of the times too, people are going after the wrong side of the joint. That's the other thing.
Talk about
Uh,
that more. Expand on that.
yeah. So what I learned from FRC was really a whole lot more about joint biomechanics that we never really got in PT school, and it's actually pretty easily explained. Maybe I just didn't understand it in PT school. Um, but we just talked about posterior glide, anterior glides in school. And basically, for those of you who don't know what those are, basically what we can do, or what we think of is a joint will be here. So we have this roll and glide, or roll and slide of a joint. All right, and now this is encapsulated, right? So we have this rotational variability too. So when we look at joints like a hip or a shoulder, which are our peripheral joints, what we want to do is actually go after the rotational aspect of this before we go into flexion or extension in these sagittal or linear planes, as FRC would call it, right? And when I treated in clinics, when I was, in clinical rotations and things in school, it was always like, yeah, you're missing flexion, just start hammering flexion, right? Hammer abduction, just push through the pain. And now what I've started doing is just going after rotation first. So with the hip, it's typically external rotation first. And then with the shoulder, it's actually internal rotation just based on mechanics. And I've seen huge differences in the clinical outcomes for people. So sometimes what we do, and it depends on the case too, but a lot of times we have hip impingement. We're looking at anterior structures. We think, yes, the TFL, the quad, the hip flexor, the psoas, all that stuff is just all these muscle attachments on the front are just pulling that joint forward. And so we're getting this symptomatic end range, this closing angle joint pain, right? But there's also this piece in the back, right? So on this backside, we have what's called the posterior capsule of a hip. And I'm trying to figure out how to orient this well. So I have all these muscles. So say this is the front of my hip, right? And this is the backside where my thumb is, right? I also have this posterior capsule. So for a joint to function, I need, yes, if these muscles are super tight in the front, they might create some symptomatology of impingement because it's brought it closer to end range, and when we go to flex, that can cause that as well. However, is that a tissue piece? Yes, and we need to learn how to assess those things as well. But from a true, just looking at the hip joint, what we see is we have this posterior capsule. So if I go to flex my hip up, right, I need this tissue between my two thumbs here, right, to be able to lengthen out so that I can flex my hip. Okay. If this is short for whatever reason, neurologically, physiologically, maybe it's just stiff, right? If I can't lengthen here, then I just get stuck up in the top of the joint. Versus if I take time to go after this posterior capsule, all of a sudden I can start sliding in the joint again without getting this. So for a lot of people, we have this anterior pain, and we constantly are rolling out, hip flexor, TFL. Oh, we're trying to do all these crazy hip flexor stretches, couch stretches, this and that, which sometimes can help. But there's also the posterior capsule. So getting into that 90-90 position with my leg up in external rotation, right? And even a lot of people will have limited internal rotation. But if I go after external rotation and hammer that posterior capsule, which is our number one piece of the rotational plane, all of a sudden after just sometimes some simple mobilizations, that thing can unlock like butter. And then it's on the patient to continue to maintain that through the week until they come back. And then we give them the next training progression of that. Um, but sometimes it's just hammering external rotation for 3 to 4 weeks, and then they come back, and then internal rotation has magically just improved because the mobility of the joint capsule itself has improved.
Hmm. That's something that I got to keep in mind as well, is the magic of like those joint mobs. And then, like you always say, clicking save with giving them those exercises. That's so big.
Yeah. So, I mean, those are the big things I can think of kind of off the top of my head of why mobility matters. And this is kind of just a big rant, which is fine because I like to rant about these things. And I think the only other thing I want to touch on is the implications for some of this stuff too. So, for those of you that are coaches and you have clients and you want to start doing some of this stuff, I think that's great. We just need to monitor the symptoms. So, the one thing we need to be careful with is selectively stretching what we need to stretch and leaving other things alone. So, what we need to be careful of is some people say they have hip pain, and maybe there's some source of it in the lumbar spine, right? And maybe they actually have uh, something going on where flexion is causing them sensitivity. And this can be symptoms just like sitting for prolonged periods of time, anytime they do forward bending activities like laundry or gardening or things, within the day to 24 hours later, they have this pain from that, right? If we go and we put them into a 90-90 position on the ground and they still aren't doing a great job of flexing their hip quite yet, um, they could potentially flex from their spine again, and then we could potentially be sensitizing that person with prolonged flexion for 3 to 4 minutes. So that's my only caveat here is we want to be careful with who we're doing this with and making sure what we're doing isn't going to flare them up or make something they're dealing with worse. But um, wholly and truly, I think going after hip mobility for strength athletes is something that can be completely um, proactive in keeping someone healthy, keeping them strong, and then long term, not seeing any poor training implications or just long term health implications from pushing through pain for years with just limited joint mobility.
For sure. And I think part of it too is just knowing why you're doing certain exercises. Like, don't just throw a bunch of hip mobility stuff at the wall and see if it helps. Know why you're doing certain ones.
Yeah, and that's why I'm a huge proponent of that FRC course. Is it just sheds so much light on why mobility is important? I don't do it justice. If you guys are interested in stuff like this, I fully suggest you listen to the Control Yourself podcast with Dr. Andrea Spina. He's a Canadian chiropractor who um, he himself rants a little bit too, but he puts a ton of good content out, and he can talk a lot more about the science and neurology and physiology of joint mobility and why it's so important. So, or you can check out the functional range conditioning course, which I've taken, and functional anatomy seminars, which is their overarching series of courses as well. Um, Connor, anything else to add? I think that kind of wraps up part two of our hip mobility here.
No, that was great. And I would just encourage everybody to come by our mobility seminars because it's not going to be like as much talking as this. It's going to be much more hands on and active. So come by, please.
Yeah, so October 23rd, we are doing a hip mobility workshop that we mentioned in part one. So it will be hands on. So people are going to be getting down. We're going to be getting on the floor. We're going to be rolling around, moving joints around, pushing them to some end ranges, and learning how to control them a little bit better to learn the most effective way to perform mobility training for performance and for health. So that kind of wraps up this episode. So if you guys like this episode, please like, rate, and share this episode so friends, family members, coworkers like you guys can also learn and benefit from this podcast. If you guys have any questions or have commentary or things you want to hear about in the future, feel free to reach us at barbelltherapyandperformance.com. Shoot us a DM on Instagram at barbell.therapy or shoot me an email at Brett with 2 T's at barbelltherapyandperformance.com. Thanks for listening, guys. Take care.